Good morning. It's really nice to see you all here. Many familiar faces, including my colleagues from the Administration for Children and Families, with whom we're collaborating closely on this project, and some familiar faces from previous work as well. So it's really nice to be included here. I don't want to duplicate work that was already done this morning, so I'm just going to go over quickly the funding for the Maternal, Infant, and Early Childhood Home Visiting Program, which is $1.5 billion over 5 years. And as you can see, the amount of money increases each year through the fourth year, and then it remains at $400 million for the last 2 years. There is a 3% set aside for research, evaluation, and technical assistance. There's also a 3% set aside for grants to tribal organizations. But what I'm going to be talking about today is the $91 million that were allocated in this first fiscal year, fiscal 2010, to the states. We're faced with an interesting challenge when this law was passed, because it was passed, as you may know, on March 23rd, and we had two obligations to fulfill within the first 6 months. First, we had to allocate all of our FY10 dollars, and secondly, the law required that the states complete statewide needs assessments that I'm going to get into in a minute. But before I do, I want to say something about the legislative purposes. Because usually when people think about this program, they think about the third purpose, which is to identify evidence-based home visiting programs and to provide the comprehensive services to improve outcomes for families who live in these at-risk communities. However, you'll see that the first two purposes are, in fact, to strengthen and improve the programs and activities under Title V, which is the Maternal and Child Health Block Grant. And second, to improve coordination of services for at-risk communities, which is an important component because we're now talking about infrastructure, not just getting those services out there, but you have to deliver these services in the context of a supporting infrastructure. As I just mentioned, we had a challenge in getting our money out and getting this program up and rolling in 6 months. And the way we were able to do that was really to divide the first year's implementation into a 3-step process. The first was that we issued a funding opportunity announcement to all of the 56 eligible entities. And we asked the states to complete their applications, to indicate that their intention to move forward in implementing a home visiting program. And we required them to get sign-off from multiple agencies across the state. So we had to have the governor designate a lead agency, which in most cases has been the Title V or the Public Health Agency. And they had to have sign-off from multiple appropriate agencies within the state government, which would include whichever agency was doing health, whichever was doing child abuse prevention and substance abuse treatment, and other agencies, because we really wanted to ensure that this was a comprehensive system. This caused a little consternation among some of the states because, like federal government, there isn't always close communication in the states among these different agencies. And they had to sign off on a plan that they all agreed upon, which was challenging, but I think it is now paying off, and we can talk about that a little bit later. On the basis of this first application, we awarded our FY10 money to the states, and it was done on a formula basis. And the formula was the same as the Title V block grant formula, which is proportion of children age 5 and under who are below poverty. The second step was, because the states were already grantees, to issue a supplemental information request for the submission of the statewide needs assessment, which of course we had to receive and be able to evaluate and approve and get into the system before the close of FY10, which was somewhat challenging because a statewide needs assessment is no small feat. And the needs assessment as we'll get into later, included multiple elements. So this was a huge challenge both for us and for the states. But I have to say that we did get the request out, and the states all got their needs assessments in on time, and they all got their FY11 block grant money. The third step, and we're engaged in this right now, is the supplemental information request for the states to submit their updated state plans. And it's an updated plan because they had to have a preliminary plan in that first application to get their money. Then when we sent their FY10 money out, it was restricted except for $500,000 per state. That money could be spent on the needs assessment itself and on planning because needs assessments are expensive and the states didn't have money for that. So they were able to spend up to $500,000 apiece in planning and needs assessment. The states now had 27 months from the date of issuance to spend that money. So we are able actually to continue the FY10 process into FY11, which is fortunate because otherwise it would never get done in any usable manner. Those final updated state plans are due to us. We gave them 90 to 120 days from the date of issuance so that they will begin to submit on May 9th, and the deadline finally is June 8th. The reason for that is there are many, many steps that the states have to undertake. Some of them may want to have asked for a re-review of certain programs they'd like to consider evidence-based, or they may need some extra time to get letters from model developers agreeing with their plans and so on. So there are multiple steps that the states have to engage in. Getting to the needs assessment, I hope. Okay. As I mentioned, the law required that the states had to conduct a statewide needs assessment and that they had to complete this by the end of fiscal 10 in order for their FY11 maternal and child health block grant funds to be issued to them. Now, it's somewhat confusing because the maternal, infant, and early childhood home visiting program is not tied to the MCH block grant, except that the states had to do this statewide needs assessment to get their block grant monies. Once they submitted those needs assessments and they got their money, the official tie between the two ended. We certainly are hoping that there's going to be a collaboration at the state level between their block grant activities and the home visiting activity. But it was something of a challenge for them to get this done in order to get their block grant money, which is substantial. Without going through to read all of these things, which you can read yourselves, you'll see that the needs assessment requirements were pretty extensive, that communities had to be identified across the state with concentrations of these many factors, including health factors, poverty factors, incidents of crime and domestic violence, school dropout rates, substance abuse, unemployment, and all of these things had to be coordinated with 3 other existing needs assessments, one of which was the Title V Block Grant Needs Assessment. Another was the community-wide strategic planning and needs assessment that's conducted as part of Head Start. And the third was the inventory of current unmet needs in current community-based and prevention-focused programs and activities under the Child Abuse Prevention and Treatment Act, CAPTA. So we have all of these requirements, and they all have to be coordinated with these other needs assessments, which all, of course, look at different kinds of things in different ways. In addition to that, the states had to identify the quality and capacity of existing state home visiting programs, including the number and types of recipients and the extent to which these programs were meeting family needs. And they had to address their capacity to provide substance abuse treatment and counseling. So you can imagine that with only a very short time to get these things done, the states were in something of a panic in some cases. I'm going to talk about what we've gone through to get that done, but first I want to explain how we are set up. I am, as was said before, I'm the branch chief of the Early Childhood Health and Development Branch. We're part of the Maternal and Child Health Bureau, which in turn is part of HRSA. The way we are divided is our project officers for the states are the people in the 10 regions, and they are the project officers for each of the states in their regions. I have 1 minute, so I'm going to quickly talk about the categories of problems that we have faced. One is data uniformity, the silos, lack of connection among the data, and the unavailability of certain kinds of data, particularly domestic violence, substance abuse, and the difficulty in achieving data from the tribal areas. Another problem is that we have many states that have identified the entire state as being at risk, or there are pockets within urban areas that don't qualify as being at risk that are, in fact, at risk, and we have to deal with drilling down problems. And we are going to have to deal with the problem of meeting community needs with models, and that's going to be happening later on in this presentation. And I just want to end by saying that there's a huge need for technical assistance out there in the states. And we have one of our providers here in the room. Child Trends has been one of our technical assistance providers. And we have done a number of webinars. We've done a lot of hands-on TA, and subsequently the states have in fact been able to get these needs assessments done. They're in the process of drilling down to identify their communities at risk, and that's where we are. Thanks.